Let's see the evaluation of ascites. The patient with ascites present with abdominal distension, the wave sign. This is, we have the abdomen of the patient that is full with third spacing. The fluid is getting out. This is the ascites. So if we put one hand here and another here, we push this, then we will feel the movement of the fluid. Sometimes we could see the veins. This would be most commonly associated with cirrhosis, but there are other causes. So the evaluation of ascites, the management would be to take a paracentesis in order to see the color and try to see the cause of ascites, because not all the time we're going to be due to cirrhosis. So we will calculate the serum albumin acidic ratio or subtraction. So it would be the serum albumin minus or subtracting the albumin of the ascites. So if this is greater than 1.1, or this could be less than 1.1, and either one of these could be greater than 2.5 or less than 2.5 grams per milliliter of proteins, and here also above 2.5 and less than 2.5 on proteins. So if the SAG is greater than 1.1, then this suggests portal hypertension, because this means that there is damage to the liver, and so the liver is producing less albumin, and so this ratio or this subtraction is greater. So if it is less than 2.5, we are talking about cirrhosis, because we have no proteins in cirrhosis. And if it is above 2.5, we can think about a pre-sinusoidal or post-sinusoidal etiology. Pre-sinusoidal could be damage before the liver, and post-sinusoidal, we are talking, for example, Budd-Chiari syndrome, or Budd-Chiari syndrome due to, for example, polycythemia vera. So in this case, we should test for that. If we find the greater than 2.5, then we should test for the mutation on the JAK2 kinase. Also, pericarditis, constrictive pericarditis, this would be pre-sinusoidal. Now, if we have a serum albumin subtraction greater and less than 1.1, then this suggests no portal hypertension. If it is above 2.5, that is, the protein is low, the total proteins are low. Remember that the normal ratio should be between 3.5 and 5.5 or 7, etc. Well, albumin is 3.5 to 5.5. The total proteins are like 7. Anyway, here, if it is less than 2.5, then it is nephrotic syndrome, because in nephrotic syndrome, the patient is bringing out the protein. If it is above 2.5, then we can think about tuberculosis, carcinomatosis, peritoneal carcinomatosis, pancreatitis, infections, etc. So, if we suspect tuberculosis, this we would suspect it with bloody appearance of the ascites fluid. So if the fluid looks bloody, we have three options. Most of the time it would be trauma or malignancy, but also could be tuberculosis. If we suspect tuberculosis, we need to do a biopsy and then send the cultures. The other causes include the pancreatitis. Pancreatitis would present with this decrease in 1.1 of the serum albumin and greater than 2.5 proteins. Also, if we see a turbid fluid, this suggests infections. And what is the most common infection? Spontaneous bacterial peritonitis. This is why in each new ascites, we need to do the paracentesis, because we don't know if it is spontaneous bacterial peritonitis. So in a patient with ascites, we need to perform the paracentesis almost every time. That is, if the patient has a new ascites, or if the ascites is getting worse, or if the patient has pain or some signs of infection. And if it is less than 1.1, so if it is less than 1.1 and we have proteins above 2.5, we suspect infection. We take the count of white blood cell count. If it is above 5, white blood cell count or neutrophil count above 250 on the ascites, then it is spontaneous bacterial peritonitis, because this is the diagnosis of spontaneous bacterial peritonitis. And if this is the case, then we need to give prophylaxis. In this case, we need to treat it. Or if we don't suspect spontaneous bacterial peritonitis, but we have that the patient has less than 1.1 of this subtraction and above 2.5, the patient is at risk of having spontaneous bacterial peritonitis. So in that case, we should give prophylaxis. And in the next video, we'll talk about the treatment and prophylaxis of spontaneous bacterial peritonitis. But the issue here is that we need to do the paracentesis in order to see if we will treat for bacterial spontaneous peritonitis or if we will prophylax the patient with spontaneous bacterial peritonitis. And this helps us, the paracentesis, and to do this analysis helps us to distinguish the etiologies of the patient with ascites. And some of the treatment includes albumin solution to replace the albumin that has been lost. So blooding will include trauma, malignancy and TB, turbid soiled infection, straw color, soiled benign cause.